presentation. Our next presenter is Vanessa Juarez. She will discuss updates in stroke rehab. Vanessa Juarez is a board-certified specialist in neurologic physical therapy. Vanessa received her bachelor's degree in kinesiology sports medicine from Rice University in 2011. She graduated from the Houston campus of Texas Women's University in 2014 with her doctorate in physical therapy and has worked in the medical center for the last 8.5 years. In her primary role as a clinician, Vanessa has gained invaluable experience working with patients diagnosed with neurological involvement and injuries. In addition to clinical work, Vanessa has also served as the Texas Women's University Houston Competency Lab Supplemental Learning Lab Coordinator. Vanessa has developed a passion for working with patients diagnosed with neurological diagnoses in the acute care and ICU setting.
All right, thank you for that introduction, and thank you for Dr. Garg and Dr. Volpe for having us here. It's truly an honor. So today I'm going to be talking about physical therapy updates in stroke rehab. So the objectives for today will be that the attendee will be able to state 3 evidence-based physical therapy interventions for stroke, and we'll have an understanding of principles related to high-intensity gait training. So just a brief outline of what I'll be talking about. I'll be talking about telerehabilitation, virtual reality, and then we'll dive deeper into locomotor training and what the evidence has to say about that. So to start with telerehabilitation, I really wanted to highlight the evidence that is out there as it relates to telerehabilitation and therapy. So let's just jump in. This first article here is actually a randomized control trial that was done in 2019. It looked at individuals that had mild to severe arm deficits. They basically had a telerehabilitation group that completed games, which were matched to functional tasks for patients that were in the clinic rehab. So the conclusion was that activity-based training produced substantial gains in arm motor function, regardless of whether it was performed in a home-based telerehabilitation setting or just in a traditional in-clinic rehab setting. Looking at systematic review for telerehabilitation that came out in 2020, basically people who received telerehabilitation also had similar outcomes for ADL function to those that received face-to-face therapy, as well as those that received no therapy. So looking at upper extremity function here for these two. So we'll take it one step further. In regard to accessibility, the systematic and review and meta-analysis showed that telerehabilitation can be a suitable alternative for usual rehabilitation care in post-stroke patients, especially in remote and underserved areas, which I think is very important for those patients, and especially with COVID, those that may not have access to in-clinic. This article kind of showed that it can be beneficial. And then one more. So in regard to motor function, ADL independence, and quality of life, telerehabilitation as an alternative form of rehab does show potential. However, there was a caveat that due to the methodological concerns and practical concerns of the way that some of the research was carried out, they stated that unequivocal recommendations actually could not be made. So one step further, one article that came out in 2020 was actually just a review by some physicians, and they really found that the evidence for telehealth to deliver stroke rehabilitation interventions is not strong and is predominantly based on small trials. So when we think about this commentary review, it's just that studies aren't powered enough to really generalize it. If we determine that a patient is appropriate for telerehabilitation, there is this Canadian Stroke Best Practice Recommendations that came out in 2022. And essentially what they said is that this is a resource for health professionals, individuals with stroke, their family caregivers, as well as healthcare administrators and potentially funders. And overall, the guidelines state that telerehabilitation should really just offer the same elements that you would find when you're doing coordinated in-person rehab services. So they give recommendations on how frequently, in terms of the duration of how this should be carried out if you are going to proceed with providing telerehabilitation for patients with stroke. So our big picture statement, so telerehabilitation may not be inferior to in-clinic rehab for upper extremity motor function. And we also need to just have a careful consideration of which patients are appropriate for telerehabilitation. A lot of the inclusion criteria was that patients needed to be able to follow commands or be more cognitively intact. So we just need to think about the safety and feasibility for patients that may be more involved if we are recommending telerehabilitation for them, that it is truly appropriate and safe. So the next topic that we'll look at is virtual reality. So this is a nice randomized control trial that came out in 2022. It was to look at the effect of, let me see here, virtual reality on the lower extremity function, and this was for chronic hemiplegic or stroke patients. So the control group just received 60 minutes of conventional therapy, and the experimental group got 30 minutes of virtual reality, and then 30 minutes of conventional therapy. So both groups got 60 minutes, and they received this 5 days per week for 6 weeks. So the conclusion was that virtual reality, in addition to conventional therapy, was found to be superior to conventional therapy alone in improving lower extremity functional status. And then kind of looking at systematic reviews and meta-analysis that have come out since, from 2016, they looked at 21 studies and found that virtual training is more effective than balance or gait training without virtual reality in improving balance and gait ability in patients with stroke. And taking it into this Cochrane review from 2017. So while they did find that just virtual reality by itself is not more beneficial than conventional therapy to improve upper limb function, when it was added to conventional therapy, there was a statistically significant difference. And really, it was just adding the total time that patients were in therapy. For gait speed and balance, there was no statistically significant effects found. So our statement here is that virtual reality may be more effective when it's added to conventional therapy for upper and lower limbs. There we go. So I just wanted to talk a little bit about where possibly the direction of research is headed for therapy and looking at functional outcomes. So again, this was a randomized control trial from 2020, and they looked at whether or not transcranial direct stimulation in addition to virtual reality versus virtual reality alone could improve upper extremity function as well as quality of life. And what they found is that actually both of them together can facilitate stronger beneficial effects on upper limb motor impairment, function, and quality of life than just virtual reality alone. So I think some of the things we may start to see coming out with research is actually combining a lot of these interventions to see if they may be good additions to conventional therapy. So now we'll kind of get into the bread and butter of the presentation. So I want to talk about locomotor training and body weight support treadmill training. So this article here is actually from the LEAPS trial that was completed in 2011. So there were 3 groups that they looked at. They had an early locomotor group, which was 2 months out from their stroke, a late locomotor group, which was 6 months out from their stroke, and then just a regular group that got a home exercise program from a physical therapist that just focused on range of motion, strengthening, balance, and coordination, and these patients were also 2 months out from their stroke. The conclusion that they came to was that locomotor training, including the use of body weight support and stepping on a treadmill, was not shown to be superior to progressive exercise at home managed by a physical therapist. And we'll get into the relevance of this later. This next article actually talks about patients that can't walk. So as part of the inclusion criteria for the LEAP study, the patients did have to be able to walk with less than 1 person assist. So it kind of limits with the severity of stroke and how these patients can present, what about those that aren't able to participate in that kind of activity? And so with this, again, it was in subacute patients, but they did find that gait training on a treadmill with body weight support is feasible and as effective as conventional gait training. So our take-home statement here is that body weight support treadmill training is actually not superior to just conventional locomotor training. So now we'll look at what about locomotor training with robotics. So in this multi-center randomized control trial that was done in 2008, their goal was actually to look at the efficacy of robot-assisted gait training with the Locomat in comparison to conventional gait training in subacute stroke population. And what they ended up finding is that the diversity of conventional gait training interventions does appear to be more effective than robotic-assisted gait training for facilitating returns to walking ability. And again, this is for subacute stroke participants. The moderate to severe gait impairments was just a range of their walking speed, not actually how much assistance they need. These patients did need to be able to walk without assistance for inclusion. And then if we look at, again, another study, but this was done with the chronic stroke population, this looked at comparing therapists versus robotic-assisted gait training, and their conclusion was that they actually did find greater improvements in speed and single-limb stance on the impaired lower extremity for the therapist-assisted locomotor training group. And again, the inclusion criteria for this was that patients had to walk without physical support, but they could use an assistive device or an AFO or an orthotic device if they needed it to walk. So our take-home picture here is that conventional or PT-assisted gait training may be more effective than robotics. We need to consider this just for patients that at the beginning of these trials were able to walk without physical assistance. But what about patients that can't? So what I found, and these were systematic reviews, and then there's one more that's a meta-analysis, but what was most interesting to me was that the patients that had the more severe impairment of their lower limb, robotic training actually produced better outcomes than conventional therapy. And then those that had the most benefit from this were within their first 3 months of stroke, but also were not able to walk at the start of the interventions that were performed. And then this meta-analysis also says that robot-assisted gait training may be more relevant for more dependent patients. So there is a possible benefit in favor of robotics for those patients that are more impaired or needing more support for locomotor training. So, all right, clear as mud, everybody got that? Cool, just kidding. So luckily, throughout the research that I was looking through, this is actually something that the Academy of Neurologic Therapy published back in 2020, and it actually is pretty nice because it does actually summarize some of the evidence that was presented earlier. So they looked at basically what came out was a clinical practice guideline to improve locomotor function following chronic stroke, incomplete spinal cord injury, and brain injury. So essentially what this looked at was the efficacy of various physical interventions to improve walking function in individuals that did have these diagnoses. And what they found was that there was really strong evidence that us as clinicians, as therapists, we should be offering walking training at moderate to high intensities in ambulatory patients. And so this led to the coining of the term high-intensity gait training. So high-intensity gait training is defined as stepping practice at high aerobic intensities without focus on training kinematics. So we're not really worried about what they look like when they're doing this. And this can be completed on a treadmill, over ground, and/or stairs. In terms of the equipment that's needed, it's actually not too much, just regular vitals monitoring, so heart rate monitors, a space for walking, or a treadmill, just to be able to get that intensity. And then just for safety, you may want to consider a harness system. The most important part here is this top piece. So what you're really targeting is a heart rate reserve of 60 to 80%, or 70 to 85% of the max heart rate. So we're really getting these patients moving, sweating, getting them working. So what they did recommend within this is that us as therapists, we do monitor their heart rate, their blood pressure, and their oxygen saturation before, during, and after, just to make sure that everything is stable during our interventions. And in terms of harm, the evidence that was found suggests that the potential for adverse events is actually no different than conventional training. So it can be a safe and feasible thing to perform, and especially because it's being monitored by a licensed physical therapist. Now, this is relevant because us as physical therapists or just part of the rehab team, we may be coming to members of either the stroke team, the rehab team, or the referring providers to get clearance for some of these patients in terms of opening a dialogue as to whether or not this intervention is appropriate for these patients. And again, just to note that this is for chronic, this clinical practice guideline was patients that are in the more chronic phase, so greater than 6 months. But there is a clinical practice guideline that will be coming out hopefully soon that looks a little bit more at the subacute aspect or the subacute population of stroke patients. Oh, okay. So this here's a snapshot. It's actually one of the resources that came out from the Academy of Neurologic Physical Therapy. So this is looking at comparing paradigms of treatments related to neuroplasticity. So when we think about our normal types of interventions that we do, we focus on impairment-based. Some of you may be familiar with NDT or Bobath interventions. So it's questionable whether or not they will target the intensity and specificity of that those aspects of neuroplasticity. And then we look at body weight supported treadmill training and robotics. So we may be able to get the specificity, we may be able to get the repetition, but the intensity is questionable as to whether or not we can get that aspect. But with high intensity gait training, we can achieve all three. So we get the specificity of gait, we get intensity via aerobic challenge, and we get repetition in terms of the continued stepping patterns. And when we allow errors in the movements that are performed, which goes back to we're going to just let the patients walk, it does facilitate motor learning. And evidence has been shown that it improves gait speed, quality of gait, symmetry, and then actually it carries over into balance and transfers. So another nice resource that came out is kind of like a green light, yellow light, red light system. So what should we be doing, what should we consider, and what should we really not be doing? So we really should be doing, as clinicians, walking training at moderate to high aerobic intensity, and walking training with virtual reality, they actually found is something that can be beneficial for patients. We may want to consider strength training at greater than 70% 1 rep max, circuit training, cycling, or recumbent stumping, and balance training with virtual reality. And we really should not be performing static or dynamic standing balance activities, including pre-gait, body weight support treadmill training with emphasis on kinematics, and robot-assisted gait training. So just to think about that, the body weight support and the robotic assisted gait training, we really shouldn't be doing unless there's concerns for safety. And it may be necessary for safe activities. So even though, again, the CPG did focus on patients that are ambulatory, it may be indicated to use the body weight support and the robotic training for patients that are non-ambulatory so we can get them up to that intensity that they need to get these neuroplastic changes. So in summary, telerehabilitation may not be inferior to in-clinic rehab for upper extremity motor function. We need to have a careful consideration of which patients are appropriate for telerehabilitation. Virtual reality may be more effective when it's added to conventional therapy for upper and lower limbs. And as it relates to locomotor training, so body weight support treadmill training is not superior to conventional therapy. Conventional or physical therapist-assisted gait training may be more effective than robotics. And there is a possible benefit in favor of robotics for those patients that are more impaired. And then the last summary, so high-intensity gait training targets specificity, intensity, and repetition to help drive neuroplasticity. Thank you.